At the onset, I would extend my sincere thanks to Dr. Bansi Sabu and the team for having invited me here and talking about what and how diabetes causes CVD in a hypertensive patient. In fact, it is a close nexus and we need to understand it. Can we have a presentation? If we look at it, cardiovascular disease is the leading cause of death among adults worldwide. And if we look at this, coronary artery disease stands on the top of all the mortality out of so many diseases. Mortality rate is double in diabetic patient because of CVD than non-diabetic patient. And if we look at this, people with diabetes has the highest incidence of ischemic heart disease and other cardiac diseases. And this comorbidity goes hand in hand, and approximately 65% of patients with diabetes die of cardiovascular and cerebrovascular diseases. It has been found out that relative prevalence under age of 55 years in diabetic patients compared to non-diabetic patients is many times, and diabetic patients are likely to have under 45 more than 11 times cardiovascular mortality than non-diabetic patients, and as the age advances, this is equally high, and 65 plus the cardiovascular mortality in diabetic patient is almost 3 to 4 times than non-diabetic patients. Now, when we sit in a clinic, we never find a isolated hypertensive or isolated diabetic, but in 70% patients will find both going hand in hand, and the combination of diabetes and hypertension has been found to be as prevalent as 70 to 75%. Now, what is the main issue? And the main issue in type 2 diabetes leading to the CVD in hypertensive patient is the insulin resistance, and which has been the integral part of all the issues which we come across. Insulin resistance is a core defect in type 2 diabetes, and a recent study shows that 92% patients with type 2 diabetes have insulin resistance. And as we know, it is the impaired response to physiological effect of insulin on all the glucose, lipid and protein metabolism, and this starts much before the development of diabetes, and it has all its consequences in hypertensive patients. When we talk about diabetes, we must know the natural history that much before the diabetes is diagnosed, the insulin resistance starts beginning, hepatic gluconeogenesis starts increasing, the endogenous insulin secretion starts falling, and at a critical level when it happens, there is a fasting at postprandial hyperglycemia, and much before the seedling of micro and macrovascular complication has taken place. There is a very interesting part that when insulin resistance has been there and hyperinsulinemia compensates for the insulin resistance, there is a normal glucose tolerance test. The moment there is a decline in the insulin secretions because of beta cell failure, the diabetes mellitus is following the impaired glucose tolerance test, and hence there is a precipitation of the hyperglycemia. What we see in clinical practice is just this tip of iceberg, but much before the diagnosis of diabetes in hypertensive patients, there is a cascade of biochemical things are happening with dyslipidemia, the high TG, the low HDL, the atherogenic dyslipidemia, as well as all seedlings for the micro and macroangiopathy are taking place much before the clinical diagnosis of diabetes. The relationship between obesity and insulin resistance and dyslipidemia, which goes with free fatty acid mobilization, insulin resistance, both leads to apolipoprotein B and hepatic lipase activity stimulation with atherogenic dyslipidemia, and which predisposes to the CVD in hypertensive diabetic patient with high TG and low HDL. Macrovascular complications are very high, and CVD, the primary cause of death among 55% of patients with diabetes. ISD is responsible for 40% of deaths, and risk of mortality is 2 to 4 times that of persons without diabetes and hypertensive patients. If you look at over the 10 years, because of CVD, the hospitalization in diabetic hypertensive patients are almost 37% higher than the normal patient. Very interesting slide. MI risk in diabetic patient without prior MI is equivalent to non-diabetic patient with myocardial infarction, and this is very interesting that non-diabetic patient who has a much lower risk of MI, while diabetic patient without prior MI is very prone to have CVD. What is the mechanism, potential mechanism for atherogenesis in diabetics who are hypertensive too? There is abnormalities in the apoprotein and lipoprotein particle distribution, glycosylation and advanced glycation of protein in the plasma and arterial wall, glycoxidation and oxidation. Procoagulant state is created and which has a tendency for atherosclerosis to take place and thrombotic things to happen. Insulin resistance and hyperinsulinemia are the one which predisposes, and many of the hormone, growth factor and cytokine, enhanced SMC proliferation and foam cell proliferation, all these leads to the severe atherogenic activity in the hypertensive diabetic patient. Why is the atherosclerosis risk in diabetics so high? There are modifiable and non-modifiable risk factors. If you look into these non-modifiable risk factors, these except smoking, all modifiable risk factors, hypertension, obesity, hyperglycemia, hyperinsulinemia, hypercholesteremia, hypertriglyceridemia and low HDL are very high in diabetic patient and non-diabetic patient. Age-associated CVD mortality according to number of CVD risk factor in risk factor trial, and we find that in diabetic patient there is almost 3 to 5 times higher risk factors than non-diabetic patient. So if we look at this, insulin resistance associated conditions, there is a cascade of conditions which are associated with insulin resistance with type 2 diabetes once it develops in hypertensive patients. There is impaired glucose tolerance test, obesity, in women polycystic ovarian disease, hyperuricemia, endothelial dysfunction, decreased fibrinolytic activity and atherosclerosis with dyslipidemia all goes hand in hand with the development of insulin resistance in hypertensive patients. Hyperinsulinemia increases risk of metabolic disorders, and this is proven and this is much higher in diabetic patients, and these are the consequences of diabetic patients. Risk of CHD mortality and degree of glucose intolerance, the Paris prospective study again confirms greater is the impaired glucose tolerance levels or the greater is the glucose level, higher is the CHD mortality, and more than 200 milligram percent fasting sugar higher will be, and more the sugar levels, more is the CHD mortality with the HbA1c higher. HbA1c is a predictor of CHD in type 2 diabetes. All CHD mortality in higher the HbA1c, which goes hand in hand with the higher mortality in hypertensive diabetic. So if we look at this, the dyslipidemia and insulin resistance, there is an enhanced VLDL secretion, increased small dense LDL particle protection, hypertriglyceridemia and decreased HDL secretion, which is a classical atherogenic composition which leads to the increased CVD in case of hypertensive diabetic patients. Insulin resistance lead to the fatty acid mobilization and dyslipidemia, decreased insulin action on lipoprotein lipase, low glucose uptake, increased rates of free fatty acid, PI1 and glycerol release, all leads to the overproduction of VLDL, which leads to the atherosclerosis in hypertensive diabetic patients. Insulin resistance and dyslipidemia ultimately leads to decreased HDL2 and increased HDL dense particles, which leads to the atherosclerosis. Dyslipidemia in men with and without type 2 diabetes. In diabetic patient, there is a higher prevalence of dyslipidemia in men, which has been proved in many trials. Same with women, especially in the postmenopausal, the diabetic women have more percentage of dyslipidemia than non-diabetic women. Significance of small dense LDL when dyslipidemic hypertensive diabetic patient, low cholesterol content of LDL particles and increased particle number for given LDL cholesterol level associated with increased level of TG and LDL-C and decreased level of HDL2, marker for common genetic trait associated with increased risk of coronary disease, possible mechanism of increased atherogenicity is greater arterial uptake, increased uptake by macrophages and increased oxidation susceptibility, all leads to the increased atherosclerosis and CVD in hypertensive diabetic patients. The effect of lipids on CHD mortality and events in middle-aged patients with type 2 diabetes, it has been found out that all dyslipidemias, adverse dyslipidemia happens in these patients with increased TC, decreased HDL-C in diabetic patients and increased TG in diabetic patients than non-diabetic hypertensive patients. Now this is a very interesting thing. How does dyslipidemia acts? And it acts through the endothelial function. Lipid lowering in dyslipidemia patient with CAD has certain advantage, and it is the endothelial dysfunction which predisposes to the CVD risk. And that's the reason all of us must be wondering that with the ADA guidelines, etc., all people diabetic above age of 40 years or all diabetic under 40 with more than 15 years of diabetic, we need to give lipids. And lipid lowering has a great advantage in preventing CVD. Why? Because reducing acetylcholine-induced endothelial-dependent coronary artery vasoconstriction reduces frequency of ST segment depression, myocardial ischemia on ambulatory ECG monitoring, increases exercise duration and reduces ischemic burden. Through the normal endothelial function, acetylcholine causes the vasodilatation. But with the endothelial dysfunction, this acetylcholine lead to the vasoconstriction, and by lipid lowering, this vasoconstriction because of endothelial dysfunction is reversed. So what should be the standards of care for glycemia, lipid and hypertension, and which we should talk about? Glycemic target for non-pregnant adult with diabetes is the preprandial sugar should be managed around 80 to 130 mg/cent, and peak postprandial should be less than 180 mg/cent. Individualized target based on age and life expectancy, comorbid conditions, diabetic duration, hypoglycemic status, individual patient consideration and known CVD advanced microvascular complications. Individualization of glycemic target for adult with diabetes, lowering HbA1c below or around 7% shown to reduce microvascular complication and macrovascular disease. More or less stringent targets may be appropriate for individual patient if achieved without significant hypoglycemia or adverse events. More stringent 6.5 if short duration diabetes is there, long life expectancy is there, no CVD vascular complications are there, then we can expect to be tight control in hypertensive patient. But we need to be less stringent if it means allowable up to less than 8. If there is a severe hypoglycemic history, limited life expectancy is there, advanced microvascular or macrovascular complications, extensive comorbid conditions, long-term diabetes in whom general HbA1c target difficult to attain. Pharmacological therapy for type 2 diabetic management in hypertensive patient. As we know, the lifestyle disease management followed by metformin, and consider insulin therapy with or without other agents if its levels are very high. Second or third line or GLP-1 analogs if levels are low. Management of high blood pressure. In such situations where there is a dyslipidemia and diabetes, measure blood pressure at every visit, confirm elevated BP at separate visit. Treatment targets are diabetes and hypertension, systolic BP preferably below 140, low systolic targets below 130 may be appropriate. There are a lot of debates going on with GNC 8 recommendations. Diabetes, diastolic may be preferably 90, low diastolic below 80 may be desirable. Now, blood pressure of 120 and 80, lifestyle changes, weight loss, DASH diet, which is in potassium ration, moderate alcohol intake and increased physical activity. Blood pressure 140 to 90, lifestyle changes, pharmacotherapy, decrease. Diabetes and hypertension, ACE and ARBs are the one which can be thought of. Treatment target for pregnant women, diabetes and hypertension around 110 to 129 systolic, 65 to 79 diastolic, with ACE and ARBs totally contraindicated and should not be thought of. CHD screening and treatment. Routine CHD screening in an asymptomatic patient not recommended. Does not improve outcome as long as CVD risk factors are treated. Lifestyle is an important part of treatment. Focus on weight loss, decrease calorie intake, increase physical activity, improve glycemic control, fitness, and some CVD risk factors are there. Over CVD, consider ACE and use aspirin and statin to reduce CV event risk factor. If hypertensive with overt CVD, aspirin, statin, ACE, ARB unless contraindication, which I will be talking later on. Pharmacologic therapy consideration for older patient may be significant factor due to polypharmacy, cost may be thing, and use cautiously thiazolidonidones with risk of cardiac failure and higher the age. Management of diabetes in pregnancy, this is a very important thing. If patient is hypertensive, diabetic in pregnancy, maintain HbA1c level as close to 7 as possible before attempting conception. Avoid Teratogenic medicines in sexually active women of childbearing age, which is very important. Statin, ACE, ARBs, and most non-insulin therapies are likely to be pregnant. Manage GDF first with lifestyle. Baseline ophthalmology examination in first trimester in women with pregnancy diabetes with hypertension. A1C target in pregnancy is less than 6% if can be achieved without significant hypoglycemia, which is very important. GDM may indicate undiagnosed type 2 diabetes. Screen women with GDM for persistent diabetes or pre-diabetes at 6 to 12 weeks postpartum every 1-3 years thereafter. Managing hypertension during pregnancy, that is a systolic blood pressure ranging from 110 to 29 and diastolic 65 to 79. ACE and ARBs should be avoided, and we can think of drugs like methyl, dopa, labetalol, diltiazem, clonidine, prazopressine. Insulin in hypertensive pregnant lady we can safely use, and it is a drug of choice we should always go for. What about ASA in first degree prevention of CVD? Aspirin for primary prevention of cardiovascular event in people with diabetes. Meta-analysis of randomized controlled trial doesn't show significant benefit. No overall benefit for major CV events in MI, stroke, CV mortality, all-cause mortality unless there is a definite indication in hypertensive patient with diabetes. Aspirin not routinely recommended for first degree prevention for CVD among patients with diabetes and hypertension. Insufficient evidence to support use of aspirin for primary prevention. Risk of bleeding and CVD protection are there. So don't forget, do your part, protect your heart, and multifaceted approach should be used when a hypertensive patient becomes diabetic, and we need to be very careful and individualize the therapy. So vascular protection checklist in a hypertensive patient who becomes diabetic. This is A1C optimal glycemic control, BP optimal blood pressure control, cholesterol LDL has to be within limits less than 100 with cardiac arrest less than 70, drugs to protect the heart, that is ACE, ARBs, statin, ASA if indicated, exercise, eating healthy, regular physical activity, achieve and maintain healthy body. Does this patient require vascular protection medication? This is a very interesting slide. Step 1. Does the patient have end organ damage? Macrovascular disease? Yes, statin plus ACE or ARB or ASA. Microvascular disease? Retinopathy, nephropathy, neuropathy? Yes, only statin. May ACE or ARBs. Step 2. What is the patient's age? If less than 55 years, patient may require statin, ACE or ARBs. 40 to 54 years, patient may require a statin. And step 3, does the patient have diabetes more than 15 years but age is under 30? Want a statin therapy based on guidelines, and a statin can be thought of. So recommendation 1, all individuals with diabetes type 1 and type 2 should follow a comprehensive multifaceted approach to reduce cardiovascular risk, including all these parameters. Recommendation 2, the statin therapy should be used to reduce CV risk in adults with type 1 or type 2 diabetes with any of the following features in hypertensive patients. Patient with microvascular disease, age above 40 years with type 2 diabetes, age under 40 years with diabetes duration more than 15 years. Recommendation 3, ACE inhibitors or ARBs at the doses that have demonstrated vascular protection should be used to reduce CV risk in adults with type 1 or type 2 diabetes when any one of the following: clinical macrovascular disease above 40 years and below 40 years as 55 years as I talked about. ASA should not be routinely used for primary prevention of cardiovascular disease in people with diabetes. ASA may be used in presence of additional cardiovascular risk factors in hypertension and diabetes. Low dose ASA therapy may be used for secondary prevention in people with established cardiovascular disease. Clopidogrel may be used if patient is unable to tolerate ASA. Take home message: diabetes is considered as a CHD equivalent. Diabetes is associated with excessive risk of cardiovascular morbidity and mortality. Macrovascular complications of diabetes begin very early in the beginning of disease in a hypertensive patient also. Coexistence of hypertension and dyslipidemia enhances the risk of CV event. Dyslipidemia in diabetes is a mixed hyperlipidemia, elevated TG, elevated LDL and low HDL. Evidence-based guidelines recommend aggressive control in blood glucose, blood pressure and dyslipidemia. Statins are aggressively recommended for primary as well as secondary prevention of CAD and diabetes. Hence, every person who is hypertensive reports to us with the 70% associated with dyslipidemia, insulin resistance and diabetes need to be evaluated for insulin resistance, or a patient having pre-diabetes or impaired glucose tolerance test, because 70% patients of hypertension goes hand in hand with this pathophysiology. Thank you.